Morning. Thank you for joining us this morning. I hope everybody's doing well. Before we get going on the presentation I put together, which is the third and final installment of the CDC guidelines, does anybody have any cases or topic of discussion that they'd like to start with? Okay. What we'll do is we'll start with the slides, and as we go, if anybody has any questions, concerns, or worries, or wants to stop and go over something, feel free to stop us at any moment. So, like I said, we've done the CDC guidelines, kind of a general overview, and then we've gone more in depth. And this is the third and final installment about the in-depth series about what the CDC has recommended. My contact information, if anybody has any questions, concerns, or worries, or just wants to reach out to me with a situation they got for help, I'm always more than willing to be there for you and help you out. As we've talked about recently, you know, is prescription drug use or misuse and abuse, is it hype or is it an American epidemic? And what we've seen over the last, since the change of paradigms in the 1990s, what we've seen is that opioid deaths have steadily increased with opioid sales, and therefore, you know, we are in an epidemic that we're trying to curb. And so in March of 2016, the CDC published guidelines for prescribing opioids for chronic pain. And what we've seen is that opioid prescribing rates have increased more with family practice, general practice, and internal medicine physicians in 2007, from 2007 through 2012. And nearly half of all dispensed opioid prescriptions come from a primary care physician. So what the CDC looked to do is set out recommendations to provide guidelines to primary care providers who are prescribing opiates for non-cancer, palliative, or end-of-life care. And the recommendations have been grouped into three areas of consideration. One was determining when to initiate or continue opiates for chronic pain. And that was our first in-depth presentation. So if you want to go online and look at that, we have those recommendations. Two, we've talked about the opioid selection, dosage, duration, follow-up, and discontinuation. We did that last month. And today what we're going to do is look at topic number 3, which is assessing risk and addressing harms of opioid use. So starting with that, the first recommendation that the CDC makes is that before starting or periodically during continuation of opioid therapy, providers should evaluate risk factors for opioid-related harms. Providers should incorporate into the pain management plan strategies to mitigate risk, including consideration offering naloxone when factors that increase the risk for opioid overdose, such as history of overdose, history of substance abuse, use disorder, or a high opioid dosage, which is greater than 15 morphine milligram equivalents in the 24-hour period. And the reasoning behind these is that certain risk factors are likely to increase the susceptibility to opioid-associated harms and warrant incorporation of additional strategies into the management plan to mitigate the risk. And if you look at the risk factors that they specifically discuss, one talk about sleep disordered breathing. If you look at this in detail, they're talking about even if they haven't been diagnosed with obstructive sleep apnea, obese patients kind of fall into this category. 2 was pregnant women, and that includes women who have already delivered and are breastfeeding. 3 was renal or hepatic insufficiency. Reason for that is that if the patients are unable to metabolize the medications appropriately, it may increase their concentration in their system, which leaves them more susceptible to an adverse event. 4 was patients greater than 65 years of age. Reasoning behind this is polypharmacy, interaction with other medications that they're on. 2 was decreased renal or hepatic function as we get older. 3 was mental health conditions, or sorry, the next one, 5 is mental health conditions. 6 was substance use disorder history. So when we see these patients, we want to make sure that from the get-go we get a good background on if they have a substance use or abuse history. And last but not least was a prior non-fatal overdose. I think studies have shown that if a patient has a prior non-fatal overdose, they're susceptible to having an adverse event again. Any questions on these risk factors? Does anyone out there think that they missed any risk factors that they should have considered? Mike, any input from you, or I think that's pretty good?
No, I think it covers a lot of front. I would add under sleep disordered breathing, I think after an individual's on opiates, you could, I think central sleep apnea is another condition following that, but many of the patients that I see with chronic pain have sleep disordered breathing as a major role, so then the opiates don't just complicate the picture.
Well, you always wonder about patients who have chronic pain if there's an underlying sleep disorder that is related or causing their chronic pain. And so a lot of times that's a nice evaluation that a patient should have who has chronic pain and make sure that that's not.
I've had a number of patients whose irritability and fatigue changes dramatically with just addressing the sleep problem, separate from their pain problem. So it's always a good idea to look at sleep.
Definitely.
Let me add one thing real quick. The prior non-fatal overdose. The reason for that is when a person is into the overdose level of using, when they stop using, and overdose is a pretty traumatic experience, so they could stop using for 3 months, 6 months, a year. If they go back, they're using the same amount, if not more. But the only thing they screwed up is their tolerance. So that's why that's even a more important marker to look for.
Yeah, I see that all the time in my clinic. I actually had a patient yesterday who, I'd seen years previous, returned to me about 2-3 months ago and was on MS Contin 300 milligrams 3 times a day with a couple of breakthrough. And, her and I had a pretty clear discussion about how we got to look at alternatives to treat her pain. Talk about strategies to reduce her over the next several months and get her within the CDC guidelines. And, saw her in July, and next thing you know, she doesn't show, no shows in August. And so you think, God, she doesn't like my strategies. She probably went back to whoever was prescribing to her before, but run a board pharmacy and it was negative, nothing shows up. So she returns yesterday. Sounds like she had some type of incident or fall on August 10th. Workup at the hospital was negative, but she was found, this fall occurred on August 10th. Friends find her on August 16th, take her to the hospital. So she laid around for 6 days with no recollection of anything that had occurred. She returned to me yesterday, and she's on literally nothing. And she's like, well, it's time to, restart my medications right where we were. And I'm like, I think I'll give you like 2 5 milligram Percocets a day. Yeah, because I think there's that fallacy that they just think, well, I used to be able to take this, so therefore I should be able to return right to that dose with no problem. But my goodness, if I would have put her on 100 milligrams 3 times a day of MS Contin, I probably would have killed her. Yeah. So, but the patients don't really understand that situation. I have to admit, in our clinic, these are probably risk factors that we should add to our intake forms, so that when we see patients initially, this is something that is asked or checked off, so we can, delve deeper into these issues. Very rarely do we outright ask patients about these situations. When I review prior medical records, usually I'll note if they have renal or hepatic insufficiency and obstructive sleep apnea. And we do have a question on our intake form about being pregnant. But as far as going in depth in mental health conditions, not really. We have a few questions asking about substance use disorder. And we have no questions whatsoever on our intake forms about if they've had a prior non-fatal overdose. So bottom line with this recommendation is essentially providers should assess for these risk factors periodically. Just because you assess them at a one-time period doesn't mean that patients can't develop these over time. Factors that vary more frequently over time require more frequent follow-up. So if, say a patient doesn't have any of these risk factors, 6 months later they've developed some of them, say you were giving them enough medications to last 2-3 months at a time, at that point you should probably reconsider how often you see them, especially after you become aware of the risk factor. You should probably start seeing them, every 30 days for a period of time. And then any patient that has a risk factor, providers should consider offering naloxone when prescribing opiates, since these patients are at increased risk. So they said situations to give naloxone is increased risk factors, history of prior overdose, patients who are taking benzodiazepines, and last but not least, patients who take over 50 morphine milligram equivalents in a 24-hour period. I just want to throw this out there. Is anybody currently in their clinic prescribing naloxone to patients? Yeah, we got one. Was it the CDC guidelines that encouraged you to do this, or were you doing it previous?
I was doing it previous, just for some of my patients who are on a lot, and they live in remote areas that don't have any medical care right now.
Let me ask you, do you do a patient education to the patient and to a family member when you initially give it to them?
I have had only a couple of times where I've been able to talk to family in person at the clinic because they travel to see me 4 hours away, so they don't often have anyone with them, but I will try to talk to the family members on the phone. And I have a handout that talks about the naloxone treatment. The problem I've had is some of them can't afford the copay.
Correct.
So that's been tough.
And that is one complaint that I hear from a lot of providers is that one, there's a prior authorization process to get the naloxone, or two, insurance won't cover it, or three, it's cost prohibitive. I think the governor's summit, that occurred last month, I think that's one of the areas that was brought up to the governor, and I think they're trying to get it so that it's almost going to be free at the pharmacy, but I don't know if that will occur. But they're trying to make it more readily available so that patients can get it even without providers prescribing it.
Yeah, that's actually taken, it was supposed to have taken effect October 1st of last year, but they ended up, it took a little bit more time to actually work out the language on it, and supposedly it was signed and ready to go when the summit took place at the end of August. Yeah, end of August. And so any time now it should be ready to, the language says that pharmacists can now furnish naloxone without a provider's prescription.
Okay. I've even heard of one situation where HHP Insurance had their pharmacy and therapeutics meeting, and they outright passed that they won't cover naloxone because their theory is that, well, if you think it's a problem, they shouldn't be on opiates in the first place. And that's not their problem to cover it. So,
but add with the naloxone, make sure that you have enough. Sometimes one is not enough. And what you're going to do is you're going to blast off those mu receptors, put the person into withdrawal, maybe be able to resuscitate them. Sometimes it takes 2 shots.
It's short acting. It only lasts 20 minutes to a half hour max.
Yeah, education is really imperative, especially I work with addiction, so know where I'm coming from, the treatment side. Some people, when they want to get as high as they possibly can, will have that in their back pocket thinking, I can really hit it, and if I do start to go into overdose, hit me with this. It's just a realistic danger that we have out there. So be aware, and with the amount of noise that they have in the system, that would be correlated to the amount that they need if they're truly going to be resuscitated. Like Chris was saying, it's time sensitive too, so they still need follow-up care.
And I have to agree. I mean, in our clinic, we've talked about adopting this, but we have not, because we're afraid that it promotes bad behavior. That I've given you this drug now that can reverse it, so why don't you go home and push the limits? Like, I feel like it's it's going to promote, bad behavior on the patient's behalf.
Sanction of it. So,
Yeah, correct.
In some thought processes, it does, because that is the thought process of the person who's struggling with addiction. They want to not only avoid pain or withdrawal, but they want to get as high as they possibly can.
You know, I guess on the flip side, I've heard one patient tell me that was a former Dr. Rand patient that he doubled her meds. I mean, like literally gave her twice as much between one visit and another without her even asking. And left the room and then came back in and said, "Oh my God, you know, I just realized I'm giving you so much that you better take this with you," and gave her a prescription of naloxone. And I guess that scared the patient, you know, so bad that she, like, I need to get out of here. I didn't even ask for an increase. He doubled my meds, and on top of it, he comes back in frantically like, "Oh, you better take this just in case." Wow. So I thought that was kind of an interesting. So maybe, you know, when you try to talk to patients about the dose they're on and you know that they're high risk, it seems to me that a lot of patients kind of look at me like, woohoo, you know, like, whatever, you know, I've been taking this forever. And I don't think they understand that it is risky. And maybe giving that prescription puts it into perspective for them. You know, I've thought about that too, but.
A lot of times if you have somebody who's accountable with them and they're trying to avoid anything, it's getting a team effort. And so it's not a one-on-one situation. It's you and your support person who have access to this, and then they can be aware. There's a couple of strategies that you can use to try to lessen the risk, and then also the education is imperative, especially how to apply it. Yeah.
All right. Any providers out there have had a patient who's been given naloxone that's how to use it? Okay. I wasn't sure if you seen any situations where patients have been given it and they actually use it, or?
No, I just heard from EMTs and people that a couple of times after they use it, that's another thing. How do you react when the person comes off of it? Are they sleepy and disoriented? Are they coming out swinging? Yeah. Are they? There's all different kinds of things that now that you've created this, now there's follow-up. And so it's the whole playing the tape all the way through. Has the person been out? Has their brain been lacking oxygen for a certain amount of time? So now we have somebody who might be even in a vegetative state when they're revived. So there's all kinds of complications that go into an overdose. And education, being aware of it, just gives you more ammunition of what to do or who to hand it off to if you get into one of those situations.
So if they're like 4 hours from a hospital and they use it, are they going to be able to revive them and actually, you know, is there going to be enough time?
They have to have 4 hours worth or enough to get them that 4 hours to the hospital.
Well, I'm assuming if they should be emergency, you know, if they contact somebody, probably somebody within a half hour. So if you give them 2 doses, seems reasonable that you can at least keep them alive until, you know, EMS gets there, and EMS at that point would then probably have enough to maintain them to get them somewhere else.
That's right. That's the standard practice, it's taking the EMS response time into account, and the EMS providers have whatever they need, the number of doses that they need in order to get to the hospital. So if it's 4 hours from the home to the hospital, then they'll have approximately 8 to 10 doses on hand for any one overdose patient.
Okay. So the next recommendation that the CDC makes is providers should review the patient's history of controlled substance prescriptions using state prescription drug monitoring program data to determine whether the patient is receiving high opioid dosage or dangerous combinations that put him or her at risk of overdose. Providers should review PDP or the database when starting opioid therapy for chronic pain and periodically during opioid therapy for chronic pain, ranging from every prescription to every 3 months. And so the reasoning behind this is that, you know, even though there was no clinical studies showing the effectiveness of a PDMP or outcomes related to overdose, addiction, abuse, or misuse. What the PDP does is it contains information on factors that could be related to an overdose. That is one, seeing patients receiving scripts from multiple providers and or receiving high total dosage of opioids. So the PDP is useful in seeing what other controlled substance a patient might be receiving from other providers that could result in a dangerous combination. So I think the main one that I look for is the combination of opioids combined with benzodiazepines. You know, previously in our clinic, we had a policy, and we still do, that we do not prescribe benzos. And when we pull the PDMP, you know, before their visit every month, I would just make sure they weren't getting opioids from another prescriber. But now that this guideline has come out, we actually take into account, you know, if they are seeing a psychiatrist and getting benzos, I'm discussing it with the patient, that it puts them at a higher risk. And two, I'm actually reaching out to the prescribing doctor and asking if there's alternatives besides benzos being on. So if they're on it for anxiety, you know, could we try an SSRI or SNRI combined with CBT instead of using chronic benzos? And in some cases, the provider agrees with this, and it you know, tells me that they'll taper them off the benzodiazepines over the next 3 to 6 months so I can continue the opioid therapy for the patient. Some situations, the patients may decide to stop the pain medication because they think they need the benzo, and so those situations, then I'm in control of weaning them off the opioid. But previously, I kind of just, you know, I said, oh, they're under another professional's care, that's fine. But I think there needs to be some coordination of care, especially since this guideline's been published. The other thing that I like about the PDMP is on the intake form. It blows me away on how many patients will put, you know, hydrocodone 10-325, 10 a day, and then I run their PDMP, and it shows that they've been getting, you know, no more than 90 every 30 days. And, you know, when you go in and start talking to the patient will, yeah, well, I'm taking 10 a day. And then I'm like, well, wait a second. You know, so you get this script for 90, you know, perfectly every 30 days. At most, that's 3 a day. How can you be taking 10? And then, you know, the truth kind of comes out. So I think, you know, patients are going to tell you on the intake forms what they want and not what they're actually taking. And so the PDMP is actually a good way to actually see what patients are currently taking or what they're receiving. So the bottom line, you know, providers should access the PDMP when starting opioid therapy, and periodically. You know, experts couldn't agree on how often, periodically would be, but they finally recommend it every so often, about every 3 months. In our clinic, we do it every visit because that's what we do. If I was a primary care physician, I'm sure I'm addressing other problems. It would be difficult to check it every month. But in our clinic, since that's all we do, we check it on every single visit. And I believe state law states that you have to check it when you're initiating or given a prescription greater than 7 days, or if you change their dose. Is that correct? Anybody else have input on that? But I think that is the state law. The other thing that I'd caution you is you got to remember that the PDMP at times is not going to include out-of-state prescriptions. Sometimes the VA does not report to the PDMP. I think they're changing that though, and I've seen situations where Indian Health doesn't. So if I have a patient that comes to me from Indian Health, a lot of times I will call the pharmacy to see if they're on. Or patients who mention to me that they are a VA patient and they go there for care, I will call the pharmacy to make sure that they're not receiving something from there. I've actually had a patient who came to me via work comp. On a side note, mentioned he was going to the VA, but you know, acted like he was out of medications. I called and found out that he had gotten 560 pills just the day before at the pharmacy. And come to find out, I think we sent him to pain psychology, and it turned out that I think Mike actually saw him, this was a couple of years ago, and found out that he was giving half those pills to his wife. So that relationship didn't last very, very long. CDC also recommends that, oh yeah, question.
So I noticed you didn't put on there the methadone clinic. I find it interesting that they don't report that either.
Yeah, so that's a great point, and I don't know if that is for privacy or HIPAA, or I'm not sure why the Center of Behavioral Health doesn't report to the PDMP as well. In drug screens, we'll see patients positive for methadone, and then when questioned about it at follow-up, which they previously never mentioned before, it'll come out that they were going to the methadone clinic before they saw us. So that is actually an excellent point too. We saw a patient in our clinic yesterday that was a Dr. Rand patient who came in, was supposedly going there, between the time Dr. Rand got arrested, between when we saw them yesterday, the PDMP was negative. Patient said they were at the Center of Behavioral Health. We actually just refused to prescribe them last week, got a drug screen, saw them back yesterday to go over the results to confirm that they're on methadone, and we also had them sign a waiver that we could call our counselor at the Center of Behavioral Health to make sure there wasn't any issues. And in this situation, it turned out the patient was compliant, had been showing up every day. They had no abnormal drug screens. So at that point, we to make it easier on the patient, we took over their methadone. We maintain it. They're around 60 milligram equivalents, and we're just going to maintain it so that instead of them coming in every day, we'd see them once a month. But yeah, does anybody know why? The reason why they don't report?
Next question.
Yeah. Another question?
I don't know. I was just curious if you knew why, or if that was going to change, because that seems ridiculous. I feel like we should know that information.
I completely agree, and I'm not sure why they don't have to report to the PDMP. I can try to look into it and see if I can get that answer for you, though.
That would be awesome. Thank you.
Hey, no problem. The other thing that I thought was interesting is if you do come across a doctor shopper, they're saying that you shouldn't use the PDMP data to dismiss patients. And they're saying that by doing so, you may adversely affect the patient's safety, and this could represent patient abandonment. Traditionally in our clinic, if we catch a patient doctor shopping, usually we would terminate care. But a lot of times that leads to hostility and kind of a hostile situation in the office. And we've kind of changed it over time that we will react to the situation. So if it's a patient who's been good, you've been checking PDMPs for years, and all of a sudden, they pop positive on the report for like 20 Vicodin, and they admit to it and say, oh, I had a dental procedure, I didn't think about calling you. A lot of times we'll give them forgiveness, but if it's a situation where you see a patient one day, the next day they get 120 from somebody else, previously in the past we would probably fire them. What we've done now, though, is try to, instead of making it a hostile situation, we kind of react to the situation where we say, well, oh my, I'm sorry, I can't prescribe to you any further. Always use kind of the government to blame. That seems to take the blame off of ourselves and de-escalate the situation, and usually give them a tapering dose. And usually what we find at that point is that the patient will terminate us. And so they'll find another provider that will continue to prescribe to them. But I think what they're trying to say is that these are golden opportunities for you to intervene in a patient's life and may have a chance to make a huge difference in outcome here. So if you can have the time to educate them on how that was wrong, how you think they may need help, offer them help, and if they get help, then you may have a chance to save that person's life. And so I think that's why they're saying that you shouldn't use that to dismiss patients. Any questions on that?
You could even use that as an opportunity to ask them, what that's about.
Correct.
Why would they be getting 150 more after they just talked to you, and see if you can elicit some response from them that could perhaps lead to some insight or an identified problem.
Yeah, and I've had situations where, I go out of my way to try to get these people help, and I tell you, it is very rare that they actually take my advice. Will end up just taking the path of least resistance, and to them, they don't think they have a problem, and the path of least resistance is just find somebody else who will continue to prescribe to them. What's nice is I think the whole Dr. Rand situation, the publication of the CDC guidelines, it seems like it's not as easy for them to find other providers now, and so I'm wondering if this whole situation that came down, you know, offering patients help, if more patients will take it because they'll find out there isn't a path that leads to resistance. And if you're curious just for individual state laws regarding the PDMPs, you can access this website for more information, but it would have any state that you'd be curious about what their the rules and regulations that they require with PDMPs. The next recommendation that the CDC has is when prescribing opiates for chronic pain, providers should use urine drug screen testing before starting opioid therapy and consider urine drug testing at least annually to assess for prescribed medications as well as other controlled prescription drugs and illicit drugs. And the reason is that concurrent use of opioids with other opioid medications, benzodiazepines, or heroin can increase the patient's risk for overdose. And that urine drug screens provide information about drug use that is not reported by the patient. Well, I don't know if that's true. All our patients are honest, aren't they? And they tell us what's going on. So it's interesting to see the results on the drug screens and you know, asking openly patients. You know, I think earlier in my career I was uncomfortable with going over the results with them, and I would almost give them a bailout, like as I would bring it up. But now usually I just slide the report across and say, hey, what's going on? And leave it open-ended and just lean back in my chair, and the story I get after that is usually pretty incredible and usually good dinner conversation to make people laugh when I'm out on weekends. The other thing that you need to know is that urine drug screens can assist providers in identifying when they're not using their medications, i.e. diverting them. So if you're giving a person 4 to 6 Percocet a day and they test negative, then you know that they're most likely diverting them or they're abusing them and they've been out of them several days before they saw you. But you need to know that urine drug screens do not provide accurate information about how much or what dose of opioids or other drugs a patient took prior to seeing you.
You know, I'm curious, Dr. Patterson, what percentage of your patients have the prescription, you do a test on, and they're not using it? Is that a low frequency or?
Well, I can give you national data. So there was in the Pain Medicine Journal about a year or 2 ago, they published urine drug screen results across the country. And what they found out is that 65% of drug screens and pain clinics were abnormal. 65%. And I'll tell you how I found this out is I was, the urine drug screening company that I was doing, they gave me a quarterly report and they handed it to me, and ours were 60% abnormal. And I was like, well, goodness, you know, if the DEA ever walked in here and they wanted to know like how thorough I was on drug screening and I handed them this report, I would be embarrassed, like completely embarrassed. What I ended up doing is I actually, but they were like, congratulations, you're better than the national average. What I ended up doing is I actually looked into the data, and what I found out is our numbers were skewed by new patients, meaning that patients who we were adopting their care, majority of those were abnormal, and patients who were in our system that we're educating, they were more in the normal range. So I went back to the drug screening company and I said, hey, I want 2 accounts. I want one account that's for new patients only, and I want a second account for my follow-ups. And what we have found is that our new patient accounts are just like the national average. We're 65, 70% abnormal, but our follow-ups, we've gotten it down to 28%. And I'll tell you what, that usually the ones that are abnormal at that point are usually patients who we've been having problems with, or 2, patients who came on a lot of short-acting, taking greater than 10 pills a day that we've transitioned to a long-acting and cut their short-acting down to no more than 1 or 2 a day. And in those situations, if the long-acting is doing its job, they probably don't need the short-acting, and so it may or may not be in their system a day or 2 before we see them. And in those situations, we wonder if our compliance is even better than 28%, because I doubt, if we're giving somebody a long-acting and it's in their system, and if it's doing the job, I doubt they're selling that extra 30, hydrocodone or Percocet we're giving them a month. So I'd encourage you, if you guys are using a drug screening company and you guys are keeping track of that data, you may want to consider getting 2 accounts, one for patients you adopt and 2, for your existing patients to see if patients are being more compliant.
One thing about drug screens too, especially if you're looking at people in addiction, is to do them consistently, because you're creating a behavior. And if the people know that they're going to be drug screened, people who are using will use that sometimes to say, I can't, and justify not using to themselves or to their friends. People who aren't using in an addiction kind of sense don't care. So it doesn't harm them at all, but it might be that catalyst to keep the person from misusing or diverting, which is really interesting too. So making a little bit extra money, or supplying their friends.
And what's interesting is I've seen situations where, I always tell mid-levels that we hire or bring in that if a person's an addict, they can't help themselves. That they're going to test positive on a drug screen, no matter how often you test them, whenever you test them, is that they're addicted. They can't stop the behavior, and you're going to catch them. Because, they know they're going to come in. They know they may have to give a random drug screen, and if they can't stop that use a couple days before, they can't, because they're addicted. And so just knowing that doing random drug screens, you may think that it may change some behavior on some patients, but a lot of times the people who are truly addicted and can't help themselves, they're still going to use.
Now, with the drug screens, the urine is important because you can get the actual numbers. And so you can create that baseline, and if that's the situation, then you expect the numbers to stay consistent or go down a little bit.
Correct.
If they continue to go up, or you use the dip just says positive. So that's telling you really nothing. That would just be more of a deterrent, where the urine will actually give you the numbers so you can work with the patient, keeping it consistent, or those numbers in the area where you think it's optimally therapeutic benefit.
Correct. The other thing that we were just talking about is stigma, is that your drug screens can be, misinterpreted. And so they're saying that you need to know how to account for metabolites, or the lack of metabolites in a drug screen. So has anybody ever heard of pill shaving? So say a patient comes to your office, they're diverting drugs. What they'll end up doing is they'll have a nail file in their pocket with one of the pills that you sold them the month before. When they go in the bathroom, they'll take their urine, which is completely negative because they're not taking the pills. They'll pee in the cup, and then they'll take the nail file and they'll file off some shavings of the pill into the sample. And what you'll see is on the results is that they'll test positive for the parent compound with no metabolites. And so therefore, the patient's not taking the drugs. They actually falsified that drug screen on the spot. So you need to be able to account for the lack of metabolites or what metabolites would be positive in a drug screen. The other thing I've seen is that providers, you need to know what's on your panel. Meaning that a couple of years ago I was talking to somebody in the community, and they're talking about the increased heroin usage, and they said, oh, I'm sure you've seen a lot of heroin in your drug screens. And I looked back and I saw 0 over the last 6 months. And then the drug screening company provided a lunch for us one day, and I started talking to them about it, and I said, oh, you're checking for the heroin metabolite? And they said, no, you're supposed to tip us off when we're supposed to check for it. And I said, oh. Yeah. And so what they showed me is that reports where there was a high morphine level, and so patients who tested, say they're on oxycodone, that had a very high morphine level, we were supposed to, and their PDMP was negative for morphine, we were supposed to assume they're using heroin and ask the company to run for the heroin metabolite. Interesting enough, we went back and looked at the last 6 months because the drug screening company, saves urine for a period of time, and I think ours is for 6 months. And we actually had them rerun about 15 samples, and they all tested positive for heroin. And those are patients who I'd given the benefit of the doubt. And actually, a couple of them I clearly remember were impaired while seeing me, so they must have, the 6-acetylmorphine literally is only in your system for several hours. So literally, those patients used heroin and showed up at my clinic within a couple hours for those urine drug screens to test positive. And so that was a lesson to me that, you know, I needed to be more aware of what was on my panel and what I was testing for.
Could you address the question? I've had patients that I've seen to say, well, I just had a poppy seed muffin before I took the test, and that became positive. Is there any validity to that?
Yes, there is. And what you'll see is it's a very low morphine level. So it'll barely go test positive over the cutoff. So if a patient has a very low morphine level and you look at the cutoff and it's barely above it, and they do give you that history, then you've got to give them the benefit of the doubt. Unless you see other metabolites associated with morphine in the drug screen, then you got to assume maybe something else. But yes, that I have seen situations.
Outside of poppy seeds and a muffin, are there any other substances that may contaminate it?
I think that's it. Yeah.
Okay.
And a lot of times patients, you know, the only other situation I've heard is, you know, if patients test positive for illicit methamphetamine, that if for some reason they're ingesting Vicks vapor rub, that may test positive for the illicit form of methamphetamine. So you just need to question if they've been using Vicks vapor rub, put it up their nose or something or Combacia. But that's pretty rare because usually they can tell between the L and the D isomer. So if a patient tries to tell you, oh, that's my amphetamine I'm taking, you know that's not true because amphetamines that are illegal will test with the L isomer, not the D isomer. Yes, question?
So I have this patient who he tested positive for methamphetamine. I'm not sure if he's one of your patients or another pain management doc, but he's always been very honest with me, and he's adamant that he's not using meth. And so is there any other medications besides the Vicks vapor rub that can cause positive methamphetamine?
Vicks is the only one. Vicks is the only drug that I'm aware of that can cause that. Here's what I'd encourage you to do. And the drug screening companies will do this for you, the urine drug screening companies. So I've had situations where patients are adamant that it's some diet supplement or something else they're taking. And what I tell them to do is bring that medication into me. I turn that over to the urine drug screening company, and they will run that pill. They will dissolve that pill into a liquid solution, and they'll run that through the LCMS with their previous urine.
Oh, okay.
If it matches up. If it matches up, then you can exonerate your patient. If it doesn't match up, then guess what? They've got some explaining to do.
Yeah, he thankfully I don't prescribe his pain medication, so I was kind of out of it. But he came in just so upset. Like, I swear I'm not using meth. So I guess I sent him to another pain management provider, and I guess he can take it up with him. But that's a good suggestion for the future. I appreciate it.
Yeah, no. There's some situations that I will actually call the pharmacist or the head technologist at the urine drug screening company, and I'll discuss the results with them and say, hey, the patient's telling me this. Is that true? And, you know, there's been a couple times where they'll exonerate the patient, or other times they'll say, that doesn't make any sense. Why don't you, you know, get one of those pills, and I'll run it against their urine and see if the results come out consistent. And, you know, every time that we've done that, it's never checked out. So I mean, if you get yourself in a situation, I'd encourage you to do that.
Which company do you guys use for your drug screen?
I use MD Labs. Their lab is located here in town.
We use the same one. They do a good job. Do you have any, I'll actually ask you that later. I'll email you.
Oh, go ahead.
We were looking into Quest. Do you know anything about the difference between using Quest labs and MD Labs? Because we have a hard time interfacing with our EMR, so we've had issues with getting the results from MD Labs, whereas we have an interface with Quest already. So I don't know if you have any experience with that.
No, I've had no experience with Quest. I just make sure that they're going to do the exact same panel. If you like MD Labs and the results they give you, but you're just having problems and you do switch, I would just make sure that they're going to give you the exact same panel that you're doing before.
Okay, perfect. Thanks.
The other thing that they said is that if you're going to test patients, don't test for things if it's not going to change the management strategy. And they specifically talk about this in the CDC guidelines. In the one area that they bring up is THC. So if a patient's using marijuana, if it's not going to change your management strategy, then you shouldn't test for it. I thought that was interesting because I see marijuana as a gateway drug, and therefore I should test for it Plus, it's illegal in the United States, and I found it interesting that the federal government was telling you not to test for it if it's not going to change your management. As an addiction specialist,
boy, you need to know what's in the person's system. And today, the marijuana is completely different than it was 20 years ago. 20 years ago, we didn't have treatment for marijuana. Now it's one of the #1 reasons for treatment for adolescents in Nevada. So we have to find out, are they taking dabs? Are they taking hash? Or are they taking flower or bud? You have to find out what's the THC level. You have to find out, are they taking edibles? You have to find out how is that going to interact with the other drugs that they're taking. Just because it's legislatively being passed, it's not medical. I have a whole thing on marijuana. As a physician, you need to know what's in that person's body. You need to know how you can optimally help them. And with marijuana right now, when you go to a bud tender, they're telling you anything that you want to hear to sell whatever they're selling. And a lot of times they're guessing on the THC level. So if the person's on an active metabolite, or THC, and they're driving and they have a benzo, if they get pulled over, they're getting multiple charges on multiple drugs. It's your responsibility to know what's in that person's system. So I'd highly recommend using THC on your panels. And a lot of them, the 5-panel drug screens will have THC.
Sure. The other thing that they were saying about is that, drug screens, some patients may feel like there's a stigmatization. And they're saying that if you're going to do drug screens, that you should be consistent, treat all patients the same to destigmatize the situation. And 2, you shouldn't use the drug screen results, once again, to terminate care. It's a moment of education. So, routine use or standardized policies in your clinical practice may destigmatize their use. And the bottom line is that urine drug screens should be utilized prior to starting opiates for chronic pain. They should be utilized periodically for chronic pain. They recommend, they couldn't come to a consensus, but they recommend about every 3 months, or they said annually. In our clinic, we have them roll dice, which is random, and we'll get 3 to 4 a year. So we're technically getting a drug screen every 3 to 4 months. And they recommend that you test urine over saliva, and that is because the window to catch the metabolites of the drug in the system is much smaller in saliva versus the urine. Just as I was saying before, you should be familiar with the drugs included in the urine drug screening testing panels, and you should understand how to interpret and understand the results. And do not test for substances for which it will not affect your management. And urine drug screening testing is intended to improve patient safety. If you do have unexpected results, then you need to look at how you're going to manage this. One, are you going to taper or discontinue the opiates based off the results that you see? Do you need to bring the patient in more frequently? So we have situations where patients test positive for a drug. It's another controlled substance that they probably got a friend for, a family member. We may start seeing them every week with a mandatory drug screen for a period of time. Once, that they start having clean drug screens, then maybe we'll see them every other week. If those are consistently good, then we'll see them every month. I can't tell you how many patients we will try to see them on a weekly basis, and they know they're being seen on a weekly basis, and I'm only giving them a week's worth of meds at a time, and they still test positive for other substances. And I think it comes back to my statement earlier, that if you're an addict, you can't stop the behavior, even if you're seeing them, once a week and only giving a short-term amount of medications to make it to those appointments. But consider, more frequent reevaluation. Patients who are test positive for other substances, consider naloxone. And bottom line, if it's a situation you don't see that you can handle, you should refer out for treatment of substance abuse disorder. And once again, they recommend that you do not terminate patients based on the urine drug screen results that may constitute patient abandonment and lead to adverse consequences for the patient's safety. This is your moment to intervene in their life and hopefully make a difference for a better outcome. The nice thing is that providers should avoid prescribing opioid pain medications when they receive benzodiazepines whenever possible. So as we all know, opioids and benzos both cause central nervous system depression. Concurrent use puts the patient at a greater risk of a fatal overdose. And basically, the use of benzos quadruples the risk compared to using opioids alone. So it drastically increases their risk of having an adverse event or a accidental overdose.
A question.
Yeah.
I had read once that benzodiazepines, from a pharmacological standpoint, are very similar to alcohol.
Correct.
Is it essentially like prescribing alcohol to someone for anxiety? Or
So when a patient gets an alcohol detox, they actually put them on benzodiazepines on a certain dose to prevent side effects, and then they wean them off the benzos when they're in acute withdrawal. So yes, they do mimic alcohol.
Yeah. I've got a number of patients that have opiates, benzodiazepines, and they use alcohol on top of that.
Yeah.
Creating huge problems.
Sounds like a smart combination.
Yeah.
So bottom line, providers should avoid prescribing opiates for patients receiving benzos whenever possible. They recommended that it's safer and more practical to taper the opioids if they've been on long-term benzodiazepines. If the patient thinks that they need the pain medications and you are going to taper the benzos, you need to do it gradually. Just remember that abrupt discontinuation of benzos can lead to rebound anxiety, hallucination, seizures, delirium tremens, and death. Even though that's very rare, opioid detoxification or taper rarely leads to death. And if you look at a tapering schedule, benzodiazepine, they recommend decreasing the dose by 20% every 1 to 2 weeks. Opioids, if you can do a rapid taper. You can do it over a 2 to 3 week period of time. But if you want to make it more comfortable for your patient, they recommend doing 10% a week. And there's better compliance with tapering when you get cognitive behavioral therapy involved during the taper. So you should probably set them up with somebody to see on a weekly basis while you're tapering them to make sure that the anxiety and other complications that may arise can be treated. The next recommendation is that providers should offer or arrange evidence-based treatment, usually medication-assisted treatment with buprenorphine or methadone in combination with behavioral therapies for patients with opioid use disorder. An opioid use disorder is a problematic pattern of opioid use leading to clinically significant impairment or distress manifested by at least 2 defined criteria occurring within a year. So these are your patients that maybe have 2 different drug screens within a year, show up impaired, once, abnormal drug screen at a different time during the year, or say they've got an abnormal PDMP drug screen or abnormal behavior. So these are characteristics you're looking for. The contextual evidence review shows that opioid agonist or partial agonist treatment with methadone, maintenance therapy, or buprenorphine in combination with psychosocial is more effective in preventing relapse than detoxification alone. And that makes a lot of sense. I think the issue here is insurance coverage. A lot of patients don't have coverage for cognitive behavioral therapy in combination, and that becomes a sticking issue. So a lot of times you have to do medication management only. Bottom line, you want to assess your patients for opioid use disorders based on patients' concerns, behaviors, PDMP data, and/or urine drug screening results. If it's not clear to you if a patient has a substance use disorder, you should refer them out to a treatment specialist to further assess if they have the disorder. And for patients who meet the criteria of opioid use disorder, you want to offer or arrange medication-assisted treatments in combination with behavioral therapies. And once again, consider offering them naloxone since they're at risk. In patients with problematic opioid use that do not meet the criteria for opioid use disorder, you should consider tapering or discontinue their opiates. If you're unable to taper, then you should probably once again offer them opioid agonist therapy. And bottom line again, you should not dismiss patients based off of a substance use disorder, as this may constitute abandonment and it may adversely affect patient safety. Once again, this is your moment to intervene and hopefully get the patient help and save a life. questions, discussion, anything we missed or patients or any of you guys would like to discuss about your patients? All right. Do we know what our topic is next month, Chris?
Off the top of my head, no.
Sorry, off the top of our head, we don't know what next month's topic is. It may be sleep or maybe...
Yeah, sleep is within the next few months. I can't remember.
Yeah, I'm checking real quick.
All right, we're checking right now. But anybody have any questions, concerns, worries?
Just a quick question. Is there a way to go back and watch the 2 previous opioid meetings that you guys had?
Yeah, so if you go to the ECHO website and go to the pain management section, I believe we have the prior 2 presentations published, correct?
The PowerPoints are up already. The videos are on another website. Happy to send them to you if you send me an email. This is Chris Marchand.
Is that Rachel? Okay, yeah.
Yeah, thank you.
So Rachel Mullenberg. Yeah, Chris will send you the links.
Next month we have 12 steps to proper opiates prescribing.
Oh, okay. So since we've covered the opioid prescribing guidelines that the CDC recommends, next month we're going to do the 12 steps to proper opioid prescribing. Any other questions? Well, hey, thank you for joining us. Always appreciate it. Hopefully you guys have a good clinic today and a good month, and we look forward to seeing you guys all next month. Thanks.
Thank you.